Thank you everyone, thank you for coming. We have a lot to get through if you've read the abstract. There's a lot to get through. In fact, it's almost a ridiculous amount to get through in 30 or 40 minutes. So it will be an overview. We won't be able to look in depth at many of the concepts that I'm going to look at today. But hopefully we'll have a robust debate and a discussion afterwards. I've titled this presentation Money and Medicine, the Odd Couple, for good reason. It's almost as though medicine is above money, that you cannot couple those two concepts together. I've been working with doctors my entire adult life, and I can tell you that one thing I've learnt in that time is that doctors do not like to talk about money. They don't like to talk about money with their patients, they don't like to talk about money with each other. But the reality is medicine and the provision of medical services is a business. And it is a substantial market where a lot of money is exchanged. So whilst medicine is steeped in noble traditions of altruism and social good, today we're going to talk about the money in the medical industry. That's what we're going to look at there on the screen. It's a lot. So I'll just get moving, and as I said, I'll keep an eye on the time, and if it runs away, we can skip over a few things. I just wanted to introduce me personally and tell you a little bit about me and my background. I'll start with my entry into the health system. So I grew up in a small country town in South Australia. And I was an incredibly rebellious teenager. And I think my mum and dad, my long-suffering, wonderful mum and dad, you know, were at the end of their tether when I got to the end of year 11 at school, which would be the 11th standard here in India. And I was failing at school. I was doing very, very badly. And it was the summer holidays, and my father, who was a high school principal, said to me one day, "You don't want to go back to school, do you, to finish school?" And I said, "No," in my rebellious tone. And he said to me, "Here's the keys to the car, go and get a job. If you come back with a job, you don't have to go back to school." So, well, that was like a red rag to a bull. I said, yes, I'm off to get a job. I was fully licensed to drive, as you could be back then at the age of 16. And I came back later that afternoon with a job, and I had a full-time job working as a nurse assistant in an aged care facility in Adelaide. I was working 6:30 to 12:30, 6 days a week, earning $60 a week. So I came back with my job, and I did not return to school, and that was my entry point into the healthcare system as a 16-year-old nurse assistant working in an aged care facility. So 35 odd years later, I am still in the healthcare system, in a very different part of the healthcare system, but over those many years I have worked in every part of the healthcare system. Inside hospitals, within hospitals, in emergency departments, as a registered nurse in the emergency department, in the intensive care units, in coronary care units, high dependency units, in operating theatres as a scrub nurse. I've worked in primary care facilities. I was even a nurse on a ship a few times. I was even the nurse at the Sydney Opera House for a while. So I've worked just about everywhere in the healthcare system. And all of that time I was married to a doctor who had no skill or interest in getting paid for his work. So I have always been managing his medical practice in the background. Even when I was, practicing as a lawyer, a litigation lawyer, and all sorts of other things. So now I find myself right at the epicentre of a healthcare system, and I'll show you that when we get to that point in the presentation. So let's just have a little look at history. I should just say that all of that experience has made me utterly fascinated with healthcare systems. I find them incredibly complex, poorly understood, and for me that just makes it all the more exciting. But they are incredibly complex systems that need to be viewed with a lot of drivers. Welcome.
Thank you.
With consideration of a lot of the drivers and the way the health market is different to other health markets. Sometimes when I listen to debates about healthcare systems, I find it exasperating because it sometimes feels as if we're discovering things for the first time, and we're not. We know a lot about healthcare systems and what works and what doesn't work. We have more than 100 years of history of healthcare systems. So the Germans, under Chancellor Bismarck, created the world's first health insurance in 1883. France and the UK followed the Bismarckian welfare state. The US and Australia were experimenting with models of health insurance from the early 1900s. We had systems before our current Medicare system. We had the Earl Page system in the early 1900s. America, I will show you, they were experimenting with healthcare systems from the early 1900s as well. Where you see most activity is after World War II. So that's where nations were rebuilding and were commencing a lot of social benefits, social welfare schemes for their populations. So most activity you see occurs after World War II. That's when the NHS was established. Australia had a major constitutional reform in 1946, which changed the direction of our healthcare system forever, and we discussed that with the team here today. The New Zealand socialised its healthcare system, the Netherlands established theirs in 1941, and then you jump to more recent times and you've got the Asia region developing their healthcare systems as well. Most recently Indonesia, Thailand, African countries. So we know a lot about what works and what doesn't work in the healthcare sector. So let's just have a look at a few key terms and definitions. What is health? So the definition most people use is the one there on your screen for from the World Health Organization. And health is a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. So that's the working definition that most people use. Universal health coverage, what does that mean? Universal health coverage, again, we use the WHO definition, defined as ensuring that all people have access to 4 things. It's promotion, prevention, cure and rehabilitation of sufficient quality to be effective, while also ensuring that people do not suffer financial hardship. Another really important term is this term health insurance. What does health insurance mean? It's actually a very misleading term, as we've been discussing this week, because insurance is contract law. So as a lawyer and a health lawyer, and there's a few other lawyers I know in the room, insurance law is essentially the law of contract. So when you talk about health insurance, you imply therefore that there is a contract between 2 parties. And in most public health insurance schemes, there is not. There is no contract between, for example, the Australian government and all the people of Australia in relation to Medicare. And the High Court has confirmed that. However, with private insurance, you do have an insurance contract and you have insurers carrying out what we refer to as insurance business. But it's quite an important distinction. So for example, Australia's healthcare system is not a law for insurance under section 14 of our constitution. Our health insurance scheme, so-called, is actually built on 2 sections of our constitution, which is section 96, which enables the federal government to give grants to the state governments to run public hospitals, and Section 5123A, which enables the federal government to make laws in relation to medical and dental services. So our health insurance scheme, and it's built on this act called the Health Insurance Act of 1973. The name of it is Health Insurance Act, but it is not insurance in the strict doctrinal sense. So when you think about, look, that aside, most countries have adopted the term health insurance to describe their health financing systems. So I've just got a screen there looking at the World Health Report and the Path to Universal Coverage, the Health Systems Financing Report, the Path to Universal Coverage. So what are we talking about when we talk about a health financing system? So to be able to achieve universal health insurance, you can't do that with the exception of a very small minority of the population, so the wealthy, without a very well-functioning health financing system. And a health financing system, really, you're talking about three things. How do we finance our system? And how do you collect money for health financing systems? There's a lot of ways. It can be general taxes, it can be specific taxes, like in Australia we have a Medicare levy. It can be the so-called sin taxes. They're becoming increasingly popular, you know, for tobacco and alcohol and sugar and so forth. There can be employer-employee contributions. So there's a whole lot of interesting ways that countries collect revenue for health. One of my favourites is an African country whose name escapes me, where they actually imposed a levy on mobile phone use. Not on consumers, but on mobile phone vendors, because everybody had a mobile phone. So they imposed a levy on the issuing of mobile phones, and they were able to raise substantial additional revenue for their healthcare system. That name will come to me. The next thing is, how are we going to distribute it? How are we going to distribute that money? And there's really only a few ways we do that, which I'll come to. And then how can you protect people from the financial consequences of ill health, and how can you encourage the optimum use of services? Health is very emotive and it divides people. So if you have a look up there, these are the comments I hear all the time. Who should pay for health? Whose role is it? So you'll hear people say people should be able to choose their own health insurance rather than have the government choose it for them. And then the left wing, it tends to be, will say, but that doesn't work because some people can't afford insurance, and they don't have the luxury of being able to choose. And then people say, well, look, you know, Mr. Joe Average, he should not have to pay to subsidise the healthcare costs of Bill Gates. You know, Bill Gates can pay for himself, you know, but of course the answer to that is, but we already pay for everyone's health, because unhealthy and sick people cost the entire nation more money, including Bill Gates. You know, but then you have people say the government should provide free health service for everyone for everything, and then the response to that is always, are you mad? That's going to send the entire country broke. So it's very emotive and very divisive. But that's just because people care a lot about health. One of my favourite comments, and I hear that very, very often, is that mandatory insurance is a form of socialism. I hear that over and over again. And it just, you know, and I hear it in America quite commonly too, and I think, well, you'd hardly describe America as a socialist country, and everyone in America has to have mandatory car insurance. It does not make them a socialist country. It doesn't make any of us a socialist country. So the concept of something being mandatory does not in and of itself make us socialist. So it's very, very divisive, but people care about it a lot. So if you look at who should pay for health, and then you look at who does pay for health, the reality is that, of course, we all do. That article up on the screen there, I've got a hard copy of it here that I'm just going to read a little bit from. Sometimes I find health journalists don't always responsibly report changes and reforms in health, largely because I think they find it very complex as well. It's very difficult to understand health. This little article that I found in the New Yorker just a few weeks back, I thought did a really good job of helping people to understand Who pays for health? It's really beautifully written. And let me just read you a couple of paragraphs from it. In 1993, the economic historian Robert Fogel wrote an influential paper, it was his Nobel Prize acceptance speech, in which he demonstrated that improvements in health accounted for fully half of the economic growth in the United Kingdom in the first 2 centuries of the Industrial Revolution. Because of improvements in sanitation, food production and medical treatment, people were living longer and spending much less time incapacitated by illness and hunger. Health was more important than railroads, electricity, mass production and every other technology we more readily associate with economic success. The flip side is true as well. A new paper by the Princeton economists Anne Case and Angus Deaton, another Nobel Prize winner, shows the intertwining nature of health and economics. This paper demonstrates that health suffers dramatically as one's job prospects dim and highlights an increase in what they call deaths of despair, including drug overdoses, suicides and alcohol-related liver mortality among older white men since 1999. There's a horrible feedback loop in which poor health can lead to bad economic outcomes, which in turn worsen health. So you can read that little phrase on the screen there yourself, but essentially the argument is that we all pay for health in some way. I was Gabon. Thank you. That was some great Googling. This is our fact checker, Tanya. It was Gabon. That's right, raised a levy on mobile phones. So let's have a look at some of the key reasons why the health market is so unique. Macroeconomics, of course, has a role to play, but it does have limitations in relation to the health market because the market doesn't behave as it is meant to. So the key reasons described throughout the literature are those on the screen: asymmetric information, the moral hazard, and the social determinants of health. So let's have a look at them. Information asymmetry and the limits of macroeconomics. So one of the issues in health is that there's an unequal relationship in the room between us and the health provider. We often don't know that we need to go to a doctor. We don't know what's wrong with us. We often need to go to a doctor to know whether we need to go to a doctor. When we purchase health, if you think about it as a purchase, we don't purchase the characteristics of the item we buy. We're actually purchasing the promise of an outcome, and that outcome is some form of improvement in our health. So we're not buying a colonoscopy. There is nothing pleasing about that. We're not buying the actual cardiac bypass. That will necessarily involve pain. There will be pain, there will be hospitalisation, there's a high amount of risk. So we're not actually buying it, we're buying the promise of a better health outcome. So the demand relates to outcome. When we buy a car, so there's a nice car yard there, it doesn't matter that we don't know how a car works. It doesn't matter. We've got equal bargaining power, we've got equal access to the market. We can Google it, we can find out what the rates are for the cars that we want to buy. We know what we want the car to do. So it doesn't matter that the car may not, we don't need to know how the car works. I don't know how a car works, doesn't matter. I know what I want my car to do. So I'm buying the actual car, not the outcome. I'm buying the car, I like the car. So the relationship in health between consumption and outcome doesn't arise when you're buying a car. The other two key factors that are different in health is unpredictability. Our need for health can go from 0 to 100% in a moment without any warning or fault, right? So we can be perfectly healthy, looking after our health, doing everything right, and just have a terrible accident befall us in a moment's notice, and suddenly we find ourselves half an hour later on an operating table and then in an intensive care unit. Another unique aspect of the health market is the actions of others can damage our health without our knowledge. And the best example of that is immunisation. So someone can choose not to immunise their children or be immunised, and that can expose us to the risk of infection, and we don't know that. So these are the key areas described in the literature, in addition to moral hazard and social determinants that we'll come to now, that make the health market not behave in the same way as other markets. It's not that macroeconomics doesn't apply. I know there's a lot of economists in the room, so it's nothing to do with that. And health economists are a very, very important part of this equation. It's just that there are limitations to the application of macroeconomics in relation to health. The next key factor in the health market is the operation of the moral hazard. So you probably all know what the moral hazard is, but it basically says I'm going to change my behaviour once I'm insured. So if you use the car example again, once I buy a brand new car and I drive out of the car yard, I'm going to behave differently and drive more carefully if I'm not insured. And if I'm insured, I don't care, because if anything happens, my insurer is going to pay. In the health market, that might happen when someone spends an extra day in hospital or has an additional procedure. Insurers have originally viewed the moral hazard unfavourably because it means that they pay out more benefits than is expected when they're setting premiums, but there is another school of thought on that I'll come to shortly. When I think about the patient moral hazard, I often think of an image like this. I think about this concept that we're going to consume more health services because it's free, because we want it. We want more health services. So if you look at that image there, that is an image of, you know, a Boxing Day sale. You probably have them here. I don't know, most countries have. You have sales, like, you know, sales. You have sales where everything's like free. You know, you can buy an LCD TV for like $20, something like that. So people rush to purchase because that's, you know, something that you would normally consume for $1,000 and you're suddenly getting it for $500, you know. So everybody, you know, there's a crush to go to the shops to consume. But, you know, think about that. Would there be the same crush if that's what we were purchasing? There's an empty shopping mall, not a lot of people there, in my imaginary shopping mall where we've got pap smear sale. It's a 2-for-1 pap smear. You can get 2 today. A run-out sale on colonoscopies. Get as many as you can. Gentlemen, get your prostate examined as many times as you can because there's a limited sale on. You can have as many as you want. So the reality is, for most of us, we don't race out to buy health services. When I talk to people about this and they say, oh, everyone's overusing services, I always stop and say to them, really, who? Well, everyone. I was like, who? Can you tell me one person that you know who is using a lot of health services? Do you use a lot of health services? I'm insured. I have absolute health insurance. I have public and private health insurance. I hate going to the doctor. I never go to the doctor. I go to the doctor less than I should go to the doctor. I go to the doctor when I'm way too sick. I don't do what I should do and go to the doctor for regular checkups. I actually don't know anyone who's just out there consuming services. The provider moral hazard. So in health, there is a moral hazard on the provider side because providers can provide more services knowing that their patients are not going to pay for them. Right? So why don't I do a little bit more? But that also doesn't operate quite the way it's supposed to in the health market. Doctors often don't know in advance that much of what they're going to provide is going to end up as waste, and it's in our interest to keep it that way. So, there's our little doctor up on the screen. Our doctor has been taught at medical school to do a differential diagnosis. Right? He or she's going to think, right, well, it could be this and it could be that, or it could be that other thing. And we always start conservatively. Don't go in with the big guns blazing. Start conservatively. I'm going to start with this antibiotic. I'm going to watch that and see how that goes. And if that doesn't work, I might have to change it. And if that doesn't work, you know, that limb might get gangrenous and then I might have to go for IV antibiotics. And then if that doesn't work, I've got a gangrenous foot. And if I can't get control of that, maybe we're going to have to amputate that limb. But we don't go in saying amputate the limb. And it's in our interest to keep it that way. So whilst there is this criticism of doctors saying they're all just over providing too many services, the reality is they are trained to treat us conservatively or in an evidence-based way based on what works most of the time. And some of it will end up as waste. And that is the truth. Is the moral hazard inefficient? Well, a new theory suggests that much of the moral hazard is actually efficient. So when the care that was deemed to be welfare decreasing is reclassified as welfare increasing, health insurance becomes much more valuable to consumers than health economists have hitherto thought it was. As a result, there's a new argument for national health insurance, and that is efficiency. So a new line of argument is that a large proportion of moral hazard health spending actually represents a welfare gain, not a loss to society. Now that's a big area of debate, and I think that health economists in the room would go mad on that, so we can talk about that later. So we'll move on now to the social determinants of health. Because another very common issue raised when we're talking about health is, what about personal responsibility? People who smoke or drink or don't exercise or are obese, I'm not paying for them. They should pay for themselves, right? So we are privileged to now have decades of work of the wonderful Professor Michael Marmot, who has spent most of his life working on the social determinants of health, as they are now known, and we have a large body of evidence. These are not things we think or feel or believe. This is now hard evidence, and there's an enormous body of it. And I was at the World Congress of Public Health just the week before last, and there's a huge stream on the social determinants of health with just more and more evidence and results of studies being presented. So there's dramatic differences in health between countries and within countries, but this is not simply a matter of rich and poor. So I recommend that book to you, Michael Marmot's book, The Health Gap. It's not just rich and poor, it actually depends on the social gradient of health, and that's one of the most interesting things in that book. If you think about health and you think about an organisational chart, so just think about an org chart for a moment, for a company org chart. Most of us, I think, well certainly myself, would think that the person on the top of the org chart who has got the most stress, 360-degree, multi-dimensional stress, 24 hours a day, 7 days a week, is the person who is at greatest risk of having some health problem. But in fact, the opposite is true. The people at the bottom of that org chart are at much greater risk in terms of their health. So the biggest study was the Shubo, remind me which study, it's the UK study, the social public service study in the UK. It was the first study that Professor Michael Marmot did to prove that point. Can't go into it in detail now, but it's a very interesting read. If there's one book that'll shift your perception of health, it is that one. It'll just make you think in a new paradigm. So let me show you a little bit about this book. So the arguments basically are health to wealth. So if we give everyone health, does that make them wealthy? In the book, he cites this Chief Medical Officer, UK, top 10 tips for health. Don't smoke. If you can, stop. If you can't, cut down. Follow a balanced diet with plenty of fruit and vegetables. Keep physically active. Manage stress by, for example, talking things through and making time to relax. If you drink alcohol, do so in moderation. Cover up in the sun, protect children from sunburn, practice safer sex, take up cancer screening opportunities, be safe on the roads, follow the highway code, and learn the first aid, ABC, airways, breathing, circulation. Nothing wrong at all with that list. And that's the type of list that you would see probably from any chief medical officer anywhere in the world today. Very sensible, very appropriate list. What Michael Marmot has argued and proved is that knowing that doesn't change your behaviour. He cites some really great examples in the book, which always make me chuckle when I read them. You know, how many times have you thought, oh, I was about to drink alcohol and have unsafe sex, but I suddenly remembered the chief medical officer's top 10 tips and I changed what I was going to do. So it's not that these are bad tips. It's just that they alone won't change behaviour. In the book, there is another list that they have compiled in support of the argument wealth to health. Here's the other alternative top 10 tips for health. Don't be poor. If you can, stop. If you can't, try not to be poor for long. Don't live in a deprived area. If you do, move. Don't be disabled or have a disabled child. Don't work in a stressful, low-paid manual job. Don't live in damp, low-quality housing or be homeless. Be able to afford to pay for social activities and annual holidays. Don't be a lone parent. Claim all benefits to which you are entitled. Be able to afford to own a car. Use education to improve your socio-economic position. So all of us could add to the list. I can add to the list. In Australia, I've added to the list in my workplace and I've said, how about we add, be born into a white middle-class English-speaking household. What about another one? Always breathe clean air. So the arguments are that if you redistribute wealth, wealth will lead to health, not the other way around. Again, these are arguments that we don't have time to go into today. So why are countries with very different health systems facing the same challenges controlling health expenditure? There's two of our recent health ministers on the screen there. We have a lot of health ministers. We've got a new one now. We have new health ministers, we have new prime ministers, we get lots and lots of changes in our ministers. So there's two of our health ministers. And some of the views that are expressed, not just by them, but by health ministers around the world, are the problem is patients. They don't look after themselves. They need a price signal. That'll stop them, right? And that health minister on the left was the one who tried to introduce co-payments in Australia, albeit unsuccessfully. Then on the right, you have no, the problem is greedy doctors. They're all out there ripping off the system. So we're going to control doctors. But the reality is neither of those points of view are actually accurate, and a balanced debate is what is required when you're talking about health. Most doctors are just trying to do the right thing by their patients, and most patients are just trying to seek the health care that they need. We know a lot about what works and what doesn't work. One of the fundamental problems is that patients don't read the packet instructions on their illnesses. It's very inconvenient. If only patients would do that. And doctors are human. Doctors are human. They will go where the incentives are. We think they're above incentives, they're not. One size doesn't fit all in health, okay? What I've learned in my work is you cannot pick up a healthcare system from one country and drop it into another country and think that's going to work. It doesn't. Healthcare systems have to be designed within the socio-political framework of the countries in which they exist. Health is very variable and highly nuanced. Mandatory schemes work best. If it's not mandatory, insurers have only one option, and that is to insure everyone as if they're sick. And that makes it expensive. Community rating and risk pooling is very effective. So by making it mandatory, you increase the size of the risk pool, and by making it having community rating, you prevent insurers from increasing premiums based on risk. So they have to rate everybody the same. So we know these things work. Prepayment versus direct contributions. Look, the jury's out on this one a bit. Most people say that even the smallest co-payment can prevent access to needed care, but there are healthcare systems in the world where there is direct contribution and they seem to work quite well. But what we also know is that healthcare systems that have the most direct contributions, and if those contributions continue to rise, they will fail over time. Primary versus tertiary care. If there's one mistake the whole world has made, in my view, it is in valuing specialist care over primary care. So we place greater value on specialists and hospital treatment, which is the most expensive part of our healthcare system, than on family medicine, general practice, outpatient services, which keep patients out of hospitals. And that is a debate that is now gaining traction around the world. Government regulation is important. You will not have a healthy functioning healthcare system without government regulation. We'll talk more about that. In terms of time, do you want me to jump over things or keep going? Do you want me to talk about the USA or do you want to skip that?
We're out of time.
So we'll skip over that. Let me just talk about how doctors are paid, because that's central to any healthcare system. So there's really only 4 ways that doctors are paid in the developed world, and they're on the screen: fee-for-service, capitation, salary, and performance-based funding. All methods have advantages and disadvantages that are well documented. In Australia at the moment, you would be forgiven for thinking that fee-for-service is the root of all of our problems, and if we take it away, all our problems will go away, and they will not. So my work in my PhD is looking at, part of it is looking at waste within a healthcare system, and what we know is that no healthcare system is free of waste. And whether your system is based fee-for-service, capitation, salary or performance-based models, you have about the same amount of non-compliant claiming. It just changes its form. So having a capitation model, you get under provision of care. And salary models, you can get under provision of care. Fee-for-service, you get over provision of care. But if you look at it, and I know this is contentious, capitation and salary-based models are actually more dangerous to human health than fee-for-service. Because fee-for-service, the minimum you will get is everything you need. Unfortunately, what you might get is more than you need, and that can sometimes be dangerous to health because you get unnecessary surgery. But the minimum you'll get is everything you need. Whereas capitation and salary, you start to get under provision of services. You know, I'm going to get the same amount of money whether I see 2 patients or 22 patients. Same with capitation. So we're moving to new models of payment, which are often called outcome-based funding, where we pay for wellness as opposed to sickness. Those models are forming, but there's a lot of problems with those models too, because how do you measure outcomes? Think about palliative care. The outcome will be death. So how do you measure that outcome? Oncology, the outcome will often be death. Rehabilitation, you're dealing with people with disabilities. So you're going to have people who are chronically disabled. They're never going to not be disabled. So how do you measure outcomes? So no model is perfect, but all models continue to evolve. So there's a lot we could talk about, but let me just finish with this. Perhaps Indonesia and Australia. No, I'll finish here. After more than 35 years working in healthcare systems, that's how I see a healthcare system. So I have providers, patients and payers. Payers can be public or private. Providers includes doctors and hospitals. Hospitals are providers of healthcare services. Allied health practitioners, nurses, administration and finance teams. Right down the bottom there, you've got health economists, medical associations, typically the AMA, the BMA, all the medical associations, health and policy experts that inform law. You have a separate administrative body to administer those laws. And right in the middle, you have these people called billers and coders, and that's me. That's where I live right now. That is where I spend my day, right in the middle. We are the people who pass the money around. So we pass it. I take it from a payer and pass it to a provider, or from a patient to a provider or a patient to a payer, or from the administrators through to, you know, patients. We sit in the middle and we see everything. Because it's not just an office-based job. You're not just sitting looking at numbers on a spreadsheet. What you're doing is you're on the phone all day talking about what happened, and that's where you learn what's going on. If you want to know what is really going on inside a healthcare system, deep inside a healthcare system, the people who know are the people in that inner circle. They know what is happening inside a healthcare system, but those people do not have a voice in health reform debate because they are not a professional body. So it's interesting that often you'll find the people who are reforming healthcare systems are not the people who actually use them or spend any time in them. And I think that is, if you were reforming a healthcare system, you need not only economists, you need lawyers, you need doctors, you need coders, you need billers, you need nurses, you need all of these people involved. In Australia at the moment, our health reform debate is being driven almost exclusively by health economists. And it's not to say that they're not an appropriate part of the debate, they absolutely are. But if they become a lone voice, we run into problems, and we're experiencing that by some of the recent reforms. Changes to our pathology, proposed changes, caused a disaster. Just because there wasn't consultation with the people who knew what was going to happen by taking an incentive payment of between $1 and $3 away from pathology providers. So that's how I see healthcare systems. There's a lot more we could talk about. Opportunities for India. Well, I'm having a wonderful week here working with this spectacular team of lawyers and economists and a dentist and all sorts of people going through all of India's healthcare schemes. And yesterday we thought there was only 19, but we actually realised there's now 40. So what that means for us is that we've now discovered that India currently has more health insurance schemes than states. There's 40 health insurance schemes operating across this wonderful country. The tertiary care focus is problematic because it's where healthcare is the most expensive. We're thinking about floating family coverage model and thinking that that's not going to be compatible with a modern mobile youth population. In every other country, individuals are insured as opposed to families, so a baby is insured from birth. Cashless transactions, though, are becoming more common in India, so there are a lot of opportunities for reform. The 2.5% allocation of GDP, you know, it's probably not enough. The WHO says that you need between 5 and 6% of GDP to come anywhere close to universal healthcare, but you've got to start somewhere. And of course there's other priorities in India in terms of, you know, sanitation and clean air and infrastructure and so forth. But it's an exciting time, and India can certainly learn from the mistakes that other countries have made in putting together a wonderful new universal healthcare system. Thank you.